In this session, we'll be dealing with the anatomy of the lungs. It is an organ of respiration. It invaginates into the pleural sac. It is covered by the visceral pleura except at hilum and pulmonary ligament. Lungs are elastic, porous, spongy structures. They crepitate on touch and they float on water. In stillborn, that is in the children born dead, lungs sink in water. So in newborns, the color is rosy pink, and in adults, it is dark slaty gray due to deposition of carbon particles. You can see here, this is the right lung. So right lung is having three lobes divided by two fissures, oblique fissure and horizontal fissure. This is the upper lobe, this is the middle lobe, and this is the lower lobe. This is the left lung. Left lung will be having two lobes. This is the upper lobe and lower lobe separated by the oblique fissure, and there is a lingula. So this lingula corresponds with the middle lobe of the right lung. So this is the apex. This will be the sharp anterior margin. So if you observe on the left side, the anterior border presents a cardiac notch, and this will be the base. This will be the inferior border. This will be the costal surface. This part will be the medial surface, and this will be the inferior surface or base or diaphragmatic surface. Posterior border is not visible here. It will be behind. It will be rounded. Presenting parts. Each lung is half conical shaped. It has an apex and a base. Base is also called as inferior surface or diaphragmatic surface, costal surface, medial surface, and three borders: anterior border, posterior border, and inferior border. So these are the lungs, and you can see here this is the part of the lung which is above the first rib. This is called as the apex. You can see here, this is the trachea, this is the principal bronchus. The principal bronchus on the right side is dividing into three lobar bronchi or the secondary bronchi for each lobe. One to the upper lobe, this to the middle lobe, and this to the lower lobe. On the left side, the principal bronchus divides into two lobar bronchi or the secondary bronchi. This is for the upper lobe and this for the lower lobe. Site determination. So apex will be placed above, sharp and thin anterior border in front. The convex costal surface will determine the side. So apex of the lung is the area of the lung above the impression of the first rib. Located at root of the neck, it is rounded in shape. The highest point of the apex is the summit. It is around 3 to 4 centimeters above first costal cartilage and 2.5 centimeters above the medial end of clavicle, but does not extend above the upper border of the neck of the first rib. So apex is covered by cervical pleura and suprapleural membrane, otherwise called Simpson's fascia. So apex vulnerable to stab wounds at root of neck, producing open pneumothorax. Relations in front: subclavian artery, then origin of internal thoracic artery, scalenus anterior close to its insertion, and subclavian vein separated from subclavian artery by scalenus anterior. You can see here, this is the cervical pleura and this is the suprapleural membrane, otherwise called Simpson's fascia, covering the apex of the lung. So behind the apex, the relations are behind the apex is in contact with the neck of the first rib, and between the apex and the first rib, from medial to lateral side, the following structures are there, namely the sympathetic trunk. So where stellate ganglion will be located, which is found with the inferior cervical ganglion plus first thoracic ganglion. Then first posterior intercostal vein, superior intercostal artery, and ascending branch of the ventral ramus of T1. So sympathetic trunk, first posterior intercostal vein, superior intercostal artery, and ascending branch of the ventral ramus of T1. You can see here, this is the ganglionated sympathetic trunk, first posterior intercostal vein, superior intercostal artery, and ascending branch of the ventral ramus of T1. So this is the apex of the lung. You can also see here the subclavian artery, subclavian vein separated by scalenus anterior. Laterally, scalenus medius and lower trunk of brachial plexus. Medially, it is different on both sides. Right side, right brachiocephalic vein, right phrenic nerve, right pericardiophenic vessels, brachiocephalic trunk, and then the trachea accompanied by right vagus nerve. On the left side, left brachiocephalic vein, left subclavian artery, left edge of esophagus, and thoracic duct. You can see here on the left side, left edge of esophagus, thoracic duct. So the apex of the lung, tumors of upper lobe of lung produces thoracic inlet syndrome by compressing structures around apex and results in following symptoms: venous enlargement and edema of the face and upper limb on affected side, diminished pulsation at wrist due to compression of the subclavian artery, paralysis of hemidiaphragm due to involvement of phrenic nerve, hoarseness of voice resulting from compression of the recurrent laryngeal nerve. Base, it is concave. The concavity is more on the right side due to presence of liver. It is semilunar. Relations are corresponding half of the diaphragm separated by pleural sac. So below the diaphragm, on the right side, there will be right lobe of liver. On the left side, left lobe of liver, fundus of stomach and spleen. Costal surface, it is convex, smooth, separated from lateral thoracic wall by costal pleura and endothoracic fascia. Presents impression for ribs and costal cartilages. So impressions are for ribs and costal cartilages, but elevations for intercostal spaces. So if you see on the costal surface of lung, whatever areas are elevated are the location of intercostal spaces. Wherever the impression or depressions are present, those are for the ribs and costal cartilages. So in the mid-clavicular line, if you observe, it is related to upper 6 ribs. In the mid-axillary line, the lung is related to upper 8 ribs. In mid-scapular line, lung is related to upper 10 ribs. Medial surface, it is having two parts. The posterior vertebral part, it is flat, related with bodies of upper 10 thoracic vertebrae and intervertebral disc between them. Posterior intercostal vessels, greater and lesser splanchnic nerves in lower part. Anterior mediastinal part, it differs on two sides. So mediastinal part of the medial surface of right lung. So first one will be the hilum of the lung and pulmonary ligament. Above downwards in the hilum, if we see, there will be epiarterial bronchus, pulmonary artery, principal bronchus and lower pulmonary vein. Before backwards, it will be upper pulmonary vein, pulmonary artery and principal bronchus with bronchial vessels. So next there will be cardiac impression, which is shallow and concave on the right side, whereas this cardiac impression will be deep and concave on the left side because heart bulges more to the left side. So on the right lung, as we are dealing with the right lung mediastinal surface, the cardiac impression here is shallow and concave. Largest following parts of the heart covered by fibrous pericardium, namely the anterior surface of the right auricle, anterior and right surface of the right atrium, and part of the anterior surface of right ventricle. And there will be a groove for inferior vena cava, posterior inferior to the cardiac impression. And there will be a groove for superior vena cava and right brachiocephalic vein from upper part of cardiac impression. Right phrenic nerve and right pericardiophrenik vessels pass along right side of these vessels. There will be a groove for arch of azagus vein above hilum and right brachiocephalic trunk impression above groove for arch of azagus vein and behind the groove for brachiocephalic vein. So if you see, majority of the veins are on the right side. So mediastinal surface of the right lung will be more related to veins, whereas mediastinal surface of the left lung will be more related to arteries. And there will be a groove behind brachiocephalic trunk, which largest trachea and right vagus nerve. And there will be a vertical groove behind hilum for right edge of esophagus. This groove does not extend above and below because esophagus deviates twice on the left side. So that's why there will be 2 times relation of esophagus on the left mediastinal surface of the left lung. As you see here, this is the mediastinal surface of the right lung. You can see here, this is the hilum. This will be the epiarterial bronchus, this will be the pulmonary artery, this will be the principal bronchus, and this will be the lower pulmonary vein. From anterior to posterior, superior pulmonary vein, pulmonary artery, and the principal bronchus. And here, if you see above the hilum, this is the groove for arch of azagus vein. And here, if you see, this will be the relationship of the esophagus on the right lung. And here you can see this will be the groove for inferior vena cava, and here you can see this is the groove for superior vena cava and the brachiocephalic vein. And here you can see this will be the groove for right brachiocephalic trunk. And this will be the groove for trachea and the right vagus nerve. And same thing, if you see on the left side, you can see this is the hilum. From upward onwards, it will be the pulmonary artery, principal bronchus, and lower pulmonary vein. From before backwards, it will be the upper pulmonary vein, pulmonary artery, and principal bronchus. And this part will be the pulmonary ligament. So here also, this is the pulmonary ligament. So here you can see above the hilum, this is the groove for arch of aorta, and behind the hilum, you can see this is the groove for descending thoracic aorta. So between the groove for descending thoracic aorta and the hilum and pulmonary ligament, there is groove for esophagus, and above the groove for arch of aorta and behind the groove for left subclavian artery, there is also again groove for esophagus. So esophagus is twice related to the left lung and only one time related to the right lung, because esophagus deviates twice on the left side. And you can also see the relationship of thoracic duct in relation to the groove for esophagus. And here, extending from the groove from arch of aorta straight vertically upwards, you can see this is the groove for left subclavian artery, and in front of it you can also see the groove for left subclavian vein. So here in front of the hilum, you can see a groove for pulmonary trunk extending just above the cardiac notch, and this is the cardiac notch. So cardiac impression. So this is the cardiac notch, which can be seen in the anterior border of the left lung, and this is the cardiac impression. So here also this will be the cardiac impression. You can see here this is the right phrenic nerve, and here you can see this will be the left phrenic nerve, and this will be the left vagus nerve. So always the vagus will be behind the hilum and phrenic will go in front of the hilum. So these are the mediastinal relations of right and left lung. So mediastinal part of the medial surface of left lung, as I said earlier, hilum of the lung and pulmonary ligament. Above downwards, it is the pulmonary artery, principal bronchus, and lower pulmonary vein. Before backwards, it will be the upper pulmonary vein, pulmonary artery, principal bronchus with bronchial vessels. So cardiac impression, it is deeply concave, largest following parts of the heart covered by fibrous pericardium, namely the anterior and left surface of the left ventricle and left auricle, anterior surface of a part of the right ventricle. Then left phrenic nerve and left pericardiophrenic vessels pass between mediastinal pleura and the pericardium. So there will be a groove for pulmonary trunk which passes upwards in front of the hilum for upper part of the from upper part of the cardiac impression. Then there will be groove for arch of aorta above the hilum. Between groove and arch of aorta, the following structures intervene, namely the left phrenic nerve, inferior cervical cardiac branch of the left vagus, superior cervical cardiac branch of the left sympathetic trunk, and left vagus nerve. Then veins, left superior intercostal vein will be there, which will pass superficial to left vagus but deep to left phrenic nerve. So there will be a vertical groove behind hilum for descending thoracic aorta, and there will be a vertical groove from the groove for arch of aorta for left subclavian artery towards apex, as we have seen in the diagram. And there will be a shallow vertical groove in front of groove for left subclavian artery for left brachiocephalic vein. And above aortic arch and behind left subclavian artery, left lung comes in contact with the left head of esophagus and thoracic duct as shown in the diagram. And there will be a shallow vertical groove running downwards and forwards between descending thoracic aorta and left pulmonary ligament. So it largest left edge of esophagus. I have shown this in the diagram. Therefore, esophagus is related twice with the left lung. You can see here esophagus is related twice with the left lung. This will be the groove for arch of aorta. This is the groove for pulmonary trunk. This is the groove for left brachiocephalic vein, and this will be the left subclavian vein. And you can see here this is a groove for esophagus. This is the groove for thoracic duct. This is a groove for descending thoracic aorta. See, if you see on the right side, it is more of if you see on the left side, it is more of arterial, and if you see on the right side, it is more of venous. So borders of the lung, anterior border, it is thin, occupies costo-mediastinal recess of the pleura. Right lung, anterior border follows costo-mediastinal reflection, whereas left lung, anterior border follows costo-mediastinal reflection only up to fourth costal cartilage, deviates laterally for 3.5 centimeters, thereafter turns downwards and medially forming cardiac notch as I have shown in the diagram, and reaches sixth costal cartilage about 4 centimeters to the left of median plane. So posterior border, it is thick, rounded, occupies paravertebral gutter. Relations, anterior margin of the heads of upper 10 ribs, sympathetic trunk, and origin of greater and lesser flanking nerves. Inferior border, it is circumscribed border, separates base of lung from costal and medial surfaces. Posterior and lateral part of inferior border is thin because it occupies costodiaphragmatic recess of the pleura. So you can see here, this will be the anterior border, and this will be the inferior border, and this will be the posterior border. This is the apex of the right lung, this is the apex of the left lung. You can see this will be the vertebral part, and this will be the mediastinal part of the medial surface of the right lung. Here also same, this will be the vertebral part, and this will be the mediastinal part of the medial surface of the left lung. Here you can see this is the oblique fissure starting from the from posterior to hilum on the medial surface, then it will cut the posterior border, then it will come across the costal surface, then again comes back to the, then again cuts and comes back to the hilum, and this will be the horizontal fissure. Here also you can see this is the oblique fissure. So lobes and fissures. Right lung, there are three lobes, upper, middle and lower, and two fissures, oblique and horizontal fissure. You can see here this is the upper lobe, this is the middle lobe, this is the lower lobe, and this will be the oblique fissure and this will be the horizontal fissure. So in the left lung you can see there is only the oblique fissure. There is an upper lobe and a lower lobe, and there is a small tongue-like projection called lingula which corresponds with the middle lobe of the right lung. You can see here right upper lobe, right middle lobe and right lower lobe. This is the left upper lobe and left lower lobe. So left upper lobe, left lower lobe, right upper lobe and right lower lobe. So this is the posterior view, and here you can see this is the right lateral view. Three lobes, right upper lobe, right middle lobe and right lower lobe. And you can see the left lateral view. So left upper lobe and left lower lobe. Oblique fissure. It begins above and behind the hilum on mediastinal surface, pass backwards and upwards as I've shown in the diagram. Cuts posterior border 2.5 centimeters lateral to the junction of T3 and T4. Passes downwards and forwards on costal surface, coincides with fifth intercostal spacing mid-axillary line. So remember this, cuts posterior border 2.5 centimeters lateral to junction of T3 and T4. Then in the mid-axillary line, if we see, it is coinciding with the fifth intercostal space. It also cuts inferior border of the lung at 6th costochondral junction, 7.5 centimeters lateral to midline, reaches lower and anterior part of the hilum. So it begins from hilum, above and behind, and it ends in front and below the hilum. So oblique fissure of left lung is more vertical. So importance acts as a plane of cleavage for allowing expansion of different parts of the lung in different directions. Horizontal fissure present only in right lung. Extent, it extends horizontally from oblique fissure in mid-axillary line up to the fourth costal cartilage. So this is an additional lobe, azagus lobe of the lung. It's also called as accessory or supernumerary lobe. Three types of azagus lobe are there: upper azagus lobe, lower azagus lobe, and lobe of azagus vein. Upper and lower azagus lobes are mentioned with reference to the hilum of the lung and are of little practical significance. What is important for us is the lobe of azagus vein. It is present in 1% of people, affects upper lobe of the right lung. Apex of the lung splits into medial and lateral parts by a fissure. The bottom of the fissure has arch of azagus vein suspended by a pleural septum called mesoazagus. Medial part of the split apex forms the lobe of azagus vein. So it develops due to growth of apical bronchus medial to the azagus vein instead of lateral to it. Then the X-ray shows dense pea-sized shadow close to right side of the sternal angle. So on X-ray we can see a peanut-sized shadow close to the right side of the sternal angle. Now you can see here, this is the azagus lobe, this is the arch of azagus vein suspended by the mesoazagus. Root of the lung, it is a tubular sheath of mediastinal pleura, connects the hilum of lung to the heart and trachea. Root contains principal bronchus, pulmonary vessels, bronchial vessels, lymphatics and nerves. It lies opposite the 5th, 6th and 7th thoracic vertebrae. You can see here, this is the hilum of the right lung, this is the hilum of the left lung, and these are the pulmonary ligaments. You can see in the right lung, it starts with an eparterial bronchus, pulmonary artery, hyparterial bronchus or principal bronchus, and the lower pulmonary vein from above downwards. So if you see on the left side, so it will be the pulmonary artery, principal bronchus and lower pulmonary vein. From before backwards, it is same on both sides, like it starts with the upper pulmonary vein, then pulmonary artery and the principal bronchus. So here also upper pulmonary vein, pulmonary artery and principal bronchus. So bronchial vessels always accompany the bronchus. Mhm. Now, what are the major differences between the right and left lung? As you see, the right lung is shorter, wider, and more capacious. So, how much short? 2.5 centimeters short. Left lung is longer, narrower, and less capacious. So, weight is around 625 grams, right lung, whereas weight of left lung is around 565 grams. There are three lobes separated by two fissures in the right lung. There are only two lobes separated by one fissure in the left lung, as we have seen earlier in the diagrams. So, base is more concave due to presence of liver. Base is shallow. So there is absence of cardiac notch and there is presence of cardiac notch in the anterior border of the left lung. So arrangement at hilum from above downwards is epiarterial bronchus, pulmonary artery, principal bronchus and lower pulmonary vein. Whereas in case of left lung it is pulmonary artery, principal bronchus and lower pulmonary vein. Cardiac compression is shallow, cardiac compression is deep. So there is absence of lingula and there is presence of lingula. Lingula corresponds with the middle lobe of the right lung. So supplied usually by one bronchial artery. Right lung is supplied by one bronchial artery, whereas left lung is supplied by two bronchial arteries. Presents 10 bronchopulmonary segments, 3 in the upper, 2 in the middle, 5 in the lower lobe. Presents 8 bronchopulmonary segments. But when we see the actual description now, even now, the left lung is having 10 bronchopulmonary segments. So one will be suppressed and two bronchopulmonary segments in the upper lobe will be separated. So there will be 8 bronchopulmonary segments in the left lung because in the upper lobe, two bronchopulmonary segments are considered together like apico-posterior, whereas in the right lung it is considered separate, apical separate and posterior separate. And in the left lung, there is one bronchopulmonary segment in the lower lobe where it will get suppressed due to presence of the heart on the left side. So we'll see those two bronchopulmonary segments which are neglected in the left lung to say it has 8 bronchopulmonary segments. But whenever you answer, you should say there are 10 bronchopulmonary segments in the left lung. I'll tell you the names of all these bronchopulmonary segments when we are dealing with the bronchopulmonary segments. So now bronchopulmonary segments. So the principal bronchi, the trachea will divide into principal bronchi. The principal bronchi will divide into lower bronchi or secondary bronchi, and these will divide into segmental bronchi or tertiary bronchi. So the portion of the lung aerated by each tertiary bronchus is called as a bronchopulmonary segment. So please remember this definition. The portion of the lung aerated by one tertiary bronchus is called as bronchopulmonary segment. It is an independent respiratory district and is wedge-shaped. Base of each segment is directed to the surface. You can see here, this is the trachea, this is the principal bronchus or primary bronchus. These are the secondary bronchi or lobar bronchi, which divides into segmental bronchus. So the area of the lung aerated by one segmental bronchus is called as bronchopulmonary segment. You can also see up to terminal bronchiole, this is the conducting part. So you have to remember this conducting part and respiratory part with respect to the nutrition of the lung when we deal with the blood supply of the lung. So individual segments are separated from each other by intersegmental areolar septa, which are occupied by intersegmental tributaries of pulmonary veins. Each tertiary bronchus is accompanied by a branch of pulmonary artery. So each tertiary bronchus is accompanied by a branch of pulmonary artery. The area of lung drained by an intersegmental tributary of pulmonary vein is called as bronchovascular unit. Bronchovascular unit. So the area of lung aerated by one tertiary bronchus is called as a bronchopulmonary segment, whereas the area of lung drained by an intersegmental tributary of pulmonary vein is a bronchovascular unit. Surgical resection of the segment produces obvious hemorrhage because intersegmentally there are tributaries of pulmonary vein. You can see here, this is the segmental bronchus and this is the pulmonary art. This is the bronchial artery and this blue color one is the pulmonary artery and this is the red color one which is the bronchial artery and this is the segmental bronchus. See, these are all within the segment, whereas if you see this, these are the tributaries of the pulmonary vein which are actually intersegmental. So number of bronchopulmonary segments in the right lung are 10. In the upper lobe, apical, posterior, anterior. In the middle lobe, lateral and medial. See the numbering. The lateral lobe is 4 and the medial lobe is 5. And in the lower lobe, again there is an apical lobe for lower lobe. It is 6. The medial basal, where we also call it as cardiac lobe. It is a 7. Then anterior basal, lateral basal and posterior basal. So it is the combination of these two segments and suppression of this segment, which makes 8 bronchopulmonary segments in the left lung. Let us see that. You can see here, these are the bronchopulmonary segments in the right lung. This will be the apical, posterior, anterior in the upper lobe. This will be the lateral and medial in the middle lobe. This will be the apical. So this will be the anterior basal, lateral basal, and posterior basal. Medial basal you can see on the medial side. So bronchopulmonary segments in the left lung. If you see, there is no middle lobe. There is no middle lobe. So middle lobe is represented by lingula. So we are having here upper lingular and lower lingular. So in the upper lobe, apical, posterior, anterior, and in the lingula, upper lingular and lower lingular. Total 5. Few books consider, in older books they used to consider apico-posterior as a single bronchopulmonary segment, but now there are three bronchopulmonary segments in the upper lobe of the left lung, apical, posterior, anterior, and two bronchopulmonary segments in the lingula, upper lingular and lower lingular. And in the lower lobe, again there are 5, namely the apical, medial basal, anterior basal, lateral basal, posterior basal. Medial basal will be suppressed due to more bulging of the heart on the left side. But ultimately, if they ask, you should tell that there are 10 bronchopulmonary segments. You can see here, apical, posterior, anterior. See the dotted line to make it as a separate, to make the count as 10. Apical, posterior, anterior, superior lingular, inferior lingular. This will be the apical, this will be the anterior basal, lateral basal, posterior basal. So medial basal is not shown here to indicate that it has been compressed by the heart. You can also see here, this is the principal bronchus, this is the trachea, this is the principal bronchus, and you can see this is the upper lobe bronchus or the secondary bronchus, and you can see 3 tertiary bronchi. Here you can see 2 tertiary bronchi, here you can see 5 tertiary bronchi, total 10 tertiary bronchi for each bronchopulmonary segment. So here also 1, 2, 3, 4, 5, 6, 7, 8, 9, and see the segmental bronchi going for the medial basal is represented by a dotted line to make it that this particular bronchopulmonary segment is suppressed. So again here also if we count, there are 10. So importance of this bronchopulmonary segment: help in drainage of infected area of the lung by adapting different postures. Yes, so anatomy of these bronchopulmonary segments will help the physician to change the position of the patient so that there will be natural drainage of the abscess from the infected lobe of the lung. Then fibroareolar septa between segments acts as natural barrier and prevent the spread of infection from one segment to other. But carcinoma and tuberculosis of the lung breaks through this barrier and spreads widely. The apical segment of lower lobe and posterior segment of the upper lobe are the commonest sites for lung abscess because they are most dependent in supine position. So aspiration pneumonia involves most frequently the apical segment of the lower lobe called as Mendelssohn syndrome. So blood supply of lungs. So there are two pulmonary arteries, one for each lung. These supply nutrition to the respiratory part of the lung, that is from the respiratory bronchial onwards. Each pulmonary artery arises from the pulmonary trunk, conveys deoxygenated blood. Branches follow the bronchial tree. Pulmonary artery lies posterolateral to the stem bronchus, whereas the branches of the pulmonary arteries follow the segmental bronchi in the following manner. Like the segmental branches of pulmonary artery in the upper lobe, if you see, they will be lying medial to the ascending bronchi. In the middle lobe, they will be cranial to the transverse bronchi, and in the lower lobe, they are lateral to the descending bronchi. So there are pulmonary veins, 4 pulmonary veins are there, 2 pulmonary veins for each lung, upper and lower. So they begin from pulmonary capillary plexus, terminates in left atrium. Tributaries are intersegmental in position. These lie anteromedial to the stem bronchus. The pulmonary artery was lying posterolateral to the stem bronchus, whereas pulmonary veins are lying anteromedial to the stem bronchus. Pulmonary vein does not convey 100% oxygenated blood because they receive deoxygenated blood from deep bronchial veins. So nutrition, the conducting part up to the beginning of the respiratory bronchioles is by the bronchial arteries. The respiratory part is supplied by the pulmonary artery. The bronchial arteries, in the right lung there is one bronchial artery. Origin differs. It can arise from any of the following ways, like descending thoracic aorta, third right posterior intercostal artery, or arise from one of the left bronchial artery. So in the left lung there are two bronchial arteries which arise from descending thoracic aorta. So bronchial arteries form two sets of branches. The tubular branches, name itself speaks, supplies terminal bronchial tubes, forms two capillary plexus, intramuscular and submucosal plexus, communicates with the branches of pulmonary arteries, finally empties into pulmonary veins through pulmonary capillary plexus. Whereas septal branches, they pass through the interlobular septa, supply pulmonary pleura, breaks into capillary plexus, drains into bronchial veins. So blood supply of lungs. So earlier we have seen the arteries, pulmonary veins and bronchial arteries. Now the last aspect of the blood supply of lung is the bronchial veins. So there are again two superficial veins and deep veins. The superficial veins will receive blood from pulmonary pleura, extrapulmonary bronchi and hilar lymph nodes. Then right side, these superficial veins will drain into arch of Ajagus vein. Left side, left superior intercostal vein or superior hemiagus vein. Superficial veins drain into right heart. Because see, if you see here, this right side they are draining into Ajagus vein, whereas left side they are draining into hemiajagus vein. Ajagus vein drains into superior vena cava, and even hemiajagus vein drains into Ajagus vein and ultimately drains into superior vena cava. Superior vena cava will open into the right atrium of heart. So that's why superficial bronchial veins will drain into the right heart, whereas deep veins they drain into the left heart. So these receive blood from intrapulmonary bronchi and bronchioles, terminates in one of the pulmonary veins or directly into the left atrium. So you can see here, these are the pulmonary veins. This is the bronchial artery. This is the pulmonary artery. These are the capillary plexus. So these are the pulmonary capillary plexus. So here you can see these are the superficial bronchial veins. You can see here these are the deep bronchial veins. And lymphatic drainage. Again, there are two sets of plexus, superficial and deep. Superficial plexus ramify beneath pulmonary pleura and around the extrapulmonary bronchi, drains into bronchopulmonary lymph nodes at hilum. Deep plexus arranged around intrapulmonary bronchi and bronchioles and also around pulmonary vessels and along interlobular septa, drain into bronchopulmonary lymph nodes. Lymph vessels in interlobular septa communicate with pleural lymphatics and are provided with valves. So in obstruction of deep lymphatics, this communication will direct the lymph to the superficial lymph vessels. Ultimately, they will go to the bronchopulmonary nodes. Most of the pulmonary lymph nodes are situated at the angular intervals of the bronchial tree. So now if you see the flow of lymph, bronchopulmonary nodes, also called as hilar lymph nodes, will drain into tracheobronchial nodes, also called as subcarinal nodes, which drain into paratracheal nodes, and then bronchomediastinal lymph trunk, and finally drains into junction between subclavian vein and interjugular vein through thoracic duct on the left side and right lymphatic duct on the right side. You can see here, these are the bronchopulmonary nodes draining into the tracheobronchial nodes, and this will be the paratracheal nodes, bronchomediastinal trunk on the left side going to the thoracic duct, on right side going to the right lymphatic duct. So now supply anterior and posterior pulmonary plexus both surround the lung root. The parasympathetic comes from both vagus nerve, right and left vagus nerve. It is bronchoconstrictor and secretomotor to the bronchial glands. Sympathetic comes from upper 4 or 5 thoracic ganglia of sympathetic trunk. Some nerve cells are present in plexus around bronchial tubes which acts as postganglion neurons of parasympathetic system. Sensory fibers are mostly conveyed by parasympathetics. So around lung alveoli, they act as stretch receptors called J receptors, which coordinate the Herring-Brewer reflex for reflex control of respiration. Irritation of the nerve fibers in bronchial mucous membrane initiates cough reflex. You can see here, these are the alveoli. These are the type 1 pneumocytes. These are the type 2 pneumocytes secreting surfactant. So type 1 pneumocytes helps in respiration. You can see this entire thing as the blood-air barrier. So type 1 pneumocyte, basement membrane of the type 1 pneumocyte, basement membrane of the capillary endothelium, and this is the endothelium of the capillaries and some part of connective tissue. So majority of the places these two basement membrane will be fused. So this forms the air-blood barrier. Applied aspects, like most commonly infection of the lungs will result in pneumonia. So pulmonary tuberculosis is the Infection of the lung by Mycobacterium tuberculosis bacillus. It is seen in immunocompromised patients like acquired immunodeficiency syndrome. Then bronchial asthma. So spasm of the bronchi may be allergic or secondary to any other condition. Bronchiectasis, atelectasis, collapse of the lung. Then emphysema, lung abscess, and bronchogenic carcinoma, malignancy of the lung. So all these are clinical aspects which will be dealt in detail in the coming years when you go for the clinics and completely understood in the final year. Thank you. So intelligence without ambition is a bird without wings.